This is my presentation on Robert Whitaker's Anatomy of an Epidemic. My first trial took about 23 to 25 minutes, so I'm hoping this will be much more concise, much more abbreviated, and still also hit the points I want to. With regards to my initial thoughts, well, for one, I am much more convinced that client-focused interventions that maybe utilize cognitive behavioral therapy, psychosocial interventions, and maybe other client-driven approaches to developing global adjustment behaviors and building social support structures. I think those frameworks are a lot more beneficial than just drug cocktails and drug-focused paradigms of care. So that's my first take, is that interventions such as like CBT or other psychosocial focused frameworks that really address the client's needs and ability to take control of working with their symptoms and having a long-term functioning lifestyle, I think, is a lot more effective than just throwing drugs at them. And you'll find a lot of case studies in the book find that roads to recovery seem to be a lot more effective when the individual was able to get off medications and sort of uphold their autonomy and be able to redirect themselves with a sense of purpose and a sense of structure around their community, their social networks, and within themselves, and really focusing on working with their symptoms rather than just kind of throwing a pill at them. My second takeaway is that I think the APA and NIMH are criminal. They've displaced a lot of patients and a lot of individuals' ability to globally adjust, ability to build strong social networks, and their long-term mental well-being. They've displaced a lot of that just to preserve this biological model and this drug-focused paradigm of care, so they can have their financial economic gains. So I think it's criminal. And I could go into that, but that's why this video took 25 minutes to begin with in the first place. So, some of the main messages too, he addresses this mental health paradigm that despite big leaps and bounds in mental health research, there's still this high prevalence of mental health disorders being diagnosed, prevalence of symptoms. There's a lot of rates of young adults going on SSIs and SSDIs. Children being diagnosed with ADHD, that's a lot more prevalent now, than it was before. A lot of affective disorders are much more common than they were about 50 years ago. So we kind of address these two things. If there's this big leap, why is it happening? And then, are medications as helpful as they say? And what you'll find is that the medications such as antidepressants, antipsychotics, Thorazine, and so on, while they might alleviate symptoms in short-term studies, that in the long run they're actually making symptoms worse. And that was my frustration with the APA and NIMH, was that there was a multitude of studies suggesting that these medications were actually making the severity and prevalence of symptoms a lot more severe. It was actually causing people to look like they had a diagnosis that they didn't. And despite a multitude of these studies saying, hey, these medications are bad, they're making symptoms worse, people are being stuck in the system, they pushed it under the rug, and they tried more so promoting their other studies that maybe advocated for medications, and these studies were not as empirically sound. Let's see. I was shocked to see what some of the side effects for some of these medications were. Like if we looked at benzodiazepine. Benzodiazepine. Yeah, I think I said that right. And like how withdrawal, you can have like double the insomnia, double the anxiety, and like huge discomforts of withdrawal. The fact that it was compared to being like more addictive than heroin, and the fact that like psychiatry and the APA were still pushing these medications, and it was still predominant in the general public narrative. The fact that all this was occurring is kind of shocking to me. Especially for some of the medications, that this was allowed to happen. Seeing long-term outcomes of like certain antipsychotics and how they block D2 receptors and actually shrink frontal lobes with chronic usage. and reading all these symptoms and how like fluoxetine actually like kind of screws up the serotonergic systems. No, I botched that one. um, read that a little too quickly. But looking at how these medications were perpetuating these like debilitating illnesses, now they kind of had to stay on them. There was like a tragic irony in like how these biological models and theories of chemical imbalance, while they were used by the APA and NIMH to explain like the disease people had, in reality, those models were better frameworks to explain what was happening to people when they were put on these medications long term, what the medications were doing to the brain. There were a lot more findings of biological chemical explanations for these rather than the diseases that were occurring, which I could be misinformed on how I structured that way of thinking, but yeah, but the overall point is that I don't agree with this drug focused usage, and even show focused on that and being really uncertain as to, because the biggest thing was that these people said we were on the verge of finding biological means of biological solutions or explanations for a lot of mental health issues, but in reality we're still not sure. And there was a study I found that kind of just highlights some of the uncertainties with what's happening with certain medications. There was a case study done in Russia with a medication called Phenibut, Phenibut. In Russia, it was meant to treat anxiety and substance use withdrawals. In the States, I think it's a nutritional supplement for sleeping. I think in Europe too. But what they found was that after it worked off of GABA B receptors, and I think it it explained it was different from how benzodiazepine, how benzodiazepine worked off of different GABA receptors, or more specific ones. How despite the Phenibut and the benzodiazepine, despite them kind of working off of different receptors, I know they were both GABA. There was distinction with the B receptors, but the withdrawal within 1 week he was experiencing psychotic symptoms, and a lot of the symptoms were similar to that of the withdrawal symptoms you'd see from being taken off benzodiazepine. So there was some stuff on GABA B receptors that probably I should do more research on, but the overall takeaway was just the fact that are we the idea that like, are we really sure that we know what's going on when we use these medications? Because despite maybe certain medications working off different receptors, it seems to like the alleviation of certain symptoms seems to be just as prevalent. Or similar. Let's see, if maybe a client with a particular diagnosis, I would say the client should be attentive to what diagnosis they've been given, especially if it's a case where Whitaker points out individuals being diagnosed with bipolar after they've been perhaps diagnosed with ADHD and been medicated with, I think, antidepressants. And looking at antidepressant-induced mania, I think especially in that context, if they've been diagnosed with something with the origins of their diagnosis, I would be cautious to be like, okay, we have to make sure this isn't like induced by the medication or if you actually have these symptoms. I would also be cautious of biological models of diagnosis and chemical imbalance theories of explanations and saying, oh, this is why you need to be on all these medications. I would instead maybe focus on environmental stressors or traumas that have not been maybe addressed yet. A lot of the case studies that Whitaker looks at and talks with different people, it seems like a lot of the symptoms become the most prevalent and severe when they have a life transition, like going to college or moving away, and they seem to detach themselves from the physical proximity of their social structures. They might have had unresolved traumas being addressed. And while there's some cases, particularly one Katie, she had schizophrenia, and she discussed being um, having a road to recovery with medications. She ultimately said the road to recovery without medications was profoundly different, and I think it worked with her a lot better. Um, but outside of that instance where it seemed medications were working, I would be cautious about using certain origins of disease that the psychiatrists, pharmaceutical companies, and like the APA were kind of pushing, and I would instead maybe focus on elements of their origin similar to like mental health recovery, where we kind of look at maybe support systems, cultural environmental influences, maybe family community strengths or weaknesses, and trying to look there in terms of where their issues might lie. Um, Let me see. I would also be cautious, and one thing Whitaker touches on, like especially in the context of maybe like ADHD or something like that, increasing diagnostic material, which might cause prevalence in people being diagnosed. Um, and a lot of these diagnoses or a lot of the improvement is really just maintaining contextual social order. And Whitaker looked at this too, but this was done in Italy, just kind of reinforces a few concepts. Um, it looked at theories for ADHD origins and treatment approaches. It discussed how a lot of symptoms for ADHD were supposed to be presenting themselves before the age of 7, but at the risk of being a bit humorous about it, if you have met anyone under the age of 7 in certain contexts, they may not want to focus on things that don't attract their attention. And that just kind of touches base on pathologizing normal experiences with kids, and trying to, instead of focus around a framework that kind of works with them socially and cognitively, just throwing a drug cocktail their way and saying, oh, they got ADHD. And in this research in Italy, they focused on a boy named Nettie. That was just the name they used. And it discussed Ritalin prescriptions for children, and how, while he was obedient, he was unable to learn at school, lacked focus, was unhappy, and socially isolated. So instead of focusing on giving them drug cocktails that kind of make them obedient in very specific tasks and social contexts, maybe work with psychosocial interventions or CBT, where they can build their social connections and be able to like refocus in context and work with different alliances and relationships, rather than prescribing Ritalin or some other medication. Also, with regards to overdiagnosing, there is one that looked at sleep duration and quality having a strong association with ADHD measures and teen delinquency, and basically just saying that like poor sleep is a strong risk modifier for teen delinquency, and a lot of characteristics in teen delinquency can be associated with ADHD. So this study also touched base on the questioning of overexpanding symptom criteria that could increase the prevalence and diagnosis, when in reality, maybe adolescents are just being adolescents, and there might need to be some family-oriented dynamic therapy that could better help alleviate these symptoms of teen delinquency. Or maybe they're just adolescents and their sleep patterns might be kind of off the charts anyway. Speaking of personal experience, like I would say mine were. I am not diagnosed with ADHD, but take that as you will. With regards to mental health recovery, we have again, like I said, there's a paradigm of care that's heavily drug driven and focused on chemical imbalances. I think we need to focus on the importance of things such as like an abundant community, strong social connections, effective healthy therapeutic alliances based on healthy communication and respect. Focus on alleviating relapse and further hospitalization that could keep clients stuck in the system, I think is really important. Maybe addressing trauma, environmental stressors, and stimuli in certain case studies. And like I said before, there could be a lot of physical, sexual abuse, maybe chronic bullying, environmental stress from higher academic institutions, and so on. There's a lot more that can explain certain behavior and prevalence rather than just giving a diagnosis that could induce symptoms, which give him another diagnosis, which give him more drug cocktails, which just further perpetuates these distressors and this anguish. So a couple of other studies I looked at. One looked at family psychoeducation and the importance of building strong alliances, and how this behavioral family management can alleviate feelings of guilt in relatives and can prevent an escalation of psychotic symptoms and improve family relationships for the client. So these positive therapeutic alliances are part of the mental health recovery model in terms of building strong social and community networks and connections that way, and building that reciprocity and respect and understanding. Also in the context of looking at therapeutic alliances with parent involvement, this model could tailor education about illnesses, behavioral management, psychotherapy, and maybe other forms of treatment for each family need. So this one's very client-focused, and getting the parents involved, and especially for like diagnosing ADHD within kids and like having adults make those decisions. And this also addresses the expansion of diagnostic criteria in ADHD, but also addresses the importance of looking at recovery holistically, building strong family, social, and community support. Overall, I would say I would be a lot more hesitant to prescribe certain medications. Now, not that as social workers you can, but I would be a lot more, I'm especially a lot more hesitant now about the validity of a lot of APA's research. I think a lot of studies and randomized controlled trials need to be a lot more thorough. I think access of information needs to be a lot more explicit and direct. And I think there's this narrative that the APA and NIMH, I think there's this narrative that they push that needs to be dramatically altered, in order to not have the general public and a lot of other people presume that you need to be on medications in order to get better, and that this idea that you're loony if you stay off the medications, and which is, I feel like, a cultural mindset that has been perpetuated for some time. I think a lot of the associations that go with that mindset need to be alleviated, and I also think that there's nothing wrong with treating mental health seriously without needing a biological explanation. I think it could be treated just as seriously. We need to build a frame. I think it's a lot of our culture around the framework of how we look at like mental health and mental illness that needs to be addressed, not necessarily whether or not a biological model is deserving of respect from a physician's viewpoint. And I know I'm over, but I just want to say I was a huge fan of the Soteria project, the schizophrenics who weren't necessarily treated with antipsychotics, and how they had better global adjustment, fewer prevalent symptoms, lower psychopathology scores, and fewer hospital readmissions. I thought Mosier's work with using carefully designed psychosocial intervention and a staff that really focused on empathy and care and respectability towards these patients, I thought it was a fantastic framework. The fact that Mosier was ostracized by the APA and NIMH, his work was written out of the psychiatric textbooks and history and narrative, I think that's disgusting. And the fact that and that's about it. Going to be super quick, and I forgot to put it in my video, but just to go back to that tragic irony of the biological model explaining what medications were doing to the brain rather than what the disease was doing to the brain, is that looking at the antipsychotics and how they were blocking D2 receptors and how long-term usage of certain antipsychotics could like shrink the frontal lobes. That's kind of more so what I was alluding to. Just this idea that like, oh, this biological model and these theories were meant to explain the disease, but if anything, they're doing a better job of explaining why the medication is causing a severity and prevalence of symptoms. Okay, now I'm done.